after muting or okay, so the first session we have covered now, overview session, and this session I mean undoubtedly has given you the insight of the remaining all session. Okay, so this is the draft document which is going to come up. The main document is going to come up in some time. So we are going to discuss now. We have a question here. Can you on the first poll, please,
Yes,
Neeraj?
sir. Yes, sir. I'm sure. Launch the poll.
How many questions are there?
So we have 5 questions in this poll. 2.5 minutes we have for polling.
So there are 5 questions. So you have 2.5 minutes. Can you make Dr. Ketan as co-host?
Yes, sure.
And me also, me, Dr. Dipasri and Dr. Ketan. Please make us.
You are already closed.
Yeah, now Dr. Ketan and Dr. Dipasri can make co-host.
Spring, spring.
Can I share the result?
Yeah, please say the result. So the first question is
I share the result.
the first question is actually a overview for you that the older method of analysis was by manual culture method, which is not, I mean, the manual culture method, you know that it is not possible to analyze the antibiogram if you use a manual culture method. So the though you may think that these are the three method of analyzing the antibiogram, but manual culture method, the manual register, if you have, then the manual register is not a method of analyzing because it is not possible to uh, uh, make the analysis from the register. Okay, the you I mean unfortunately in India majority of the lab are maintaining the manual register, and with manual register antibiogram is never going to work out. Okay, the basic reason is we do not have all data and how to analyze the data unless otherwise it is digitalized. Okay, the next option is Excel based analysis. Excel based analysis, though many of the lab are doing, but how will you follow the complex antibiogram rules? How you are going to implement if you have Excel based data? I mean, it is better than having a manual data, but however, the complex antibiogram rule, the first isolate to select, the various type of filters to apply, it is practically not possible to use a Excel to have a competent antibiogram report. Okay, and also in Excel every time you have to analyze by yourself, whereas if you have a digitalized data collection, that is data analysis software, the data analysis software has the capacity to analyze the data in a fraction of second and will display in front of you, unlike Excel where the data you have to do it by yourself, you have to analyze the data every time you want to uh, analyze. So Excel is not a solution. A register, manual register is also not a solution. Don't think these are standby option. The only way of analyzing the antibiogram is you should have information system designs, or also called as data analysis software. The data analysis software can be there at three places. It can be there in the inside the AST instrument, like every AST instrument, like whether it is a Vitek or a Phoenix or microscan, these are the three AST instruments are available, although Vitek is more widely used in India. So within this three system they have their own data analysis software. So this is one way of analyzing, or you can locally develop the data analysis software with the help of your laboratory information system or electronic health record of your hospital. So these are the two places where you have IT wings available, so you can take help of your IT wing, and you can locally develop the data analysis software in your within your LIS. Otherwise, you can use a third party antibiogram software as a part of the clinical decision support system. There are various third party antibiogram softwares are available. You can hire those software, and you can connect this software with to your LIS, so that you can take the you can collect you can connect this type of third party software with your Vitek machine. You can collect to collect the AST data, and this kind of software you can also connect with your LIS to take the patient related informations, and the antibiogram software will analyze by itself. So all the three methods are available. However, however, it is, I mean, the locally developed LIS is very difficult, because those complex antibiogram analysis pathways, those complex rules what need to be applied, it is very difficult to explain your LIS team, your IT wing, to develop a local antibiogram software by yourself. It is, though theoretically it may sound to be possible, but practically I can say that it is impossible for us to in our respective IT wing in every institute, is not possible to educate them about the complex antibiogram rules. AST instrument, the advantage is this kind of software is completely free of cost, because it is available within Vitek itself. However, these are not user friendly software. These softwares are not user friendly. They have various limitations. The filters you cannot apply adequately, especially the patient related informations are limited. The patient related informations are usually limited available inside the Vitek equipment. So all kind of data analysis is not possible. Maybe a routine antibiogram or a sample specific antibiogram you can make, but detailed antibiogram is practically not possible, and most of the rules are fixed by the AST company by itself. You will not be able to know which rules they have applied. They will tell that we have followed the CLSI guideline, but all the rules adequately applied. You cannot validate the rules. So this is again a drawback of AST. instrument based software. Therefore, the best possibility in today's date is a third party antibiogram software, like for example, WhoNet is one of the freely available third party antibiogram software, which is available, all of us can use. Now ICMR is going to come up with a third party antibiogram software, which most of the ICMR network labs are using. So you can use such third party antibiogram software.
Can
So
I give a submission, sir?
yes.
Yeah. If anybody is using a Excel or a LIS, that can still be read with, analyzed with TUNET, because there is something called backlinks now. With
Back
the backlink, if we see the Excel, it can
yeah.
still analyze the data.
From the Vitek, the data can go to WhoNet.
Yes, sir. From
A
no,
software
from
called
Vitek also it
back.
can go. From Excel also it can go. From LIS also it can go.
Yeah,
Yeah.
but WhoNet has its own limitations. WhoNet, again, you have to manually enter the data,
And
or you
no,
can put the data from AST instrument, of course. But
there-
all kind of data, all kind of filters, you may not be able to apply. You can have a
have
you can
our own filters. We can create our own filters, and we can take even LIS. LIS from the database, it can be directly fed into the HUNET.
Yeah, yeah.
Yes.
So that's what I told, that WhoNet is again a validated. Can you make a combination antibiogram in WhoNet?
Make, yes, sir, we can make,
Combination
sir.
antibiogram.
Yes, sir, we can. I think the recent version is allowing for combination, few of the combination.
Yeah. So I was told that some of the WhoNet users, what their experience they have shared with me, that many things are possible, but still there are some limitations. All kind of stratifications, combination agent, or maybe outbreak detection. All aspects may not be possible, but yes, WhoNet is of course
One
WhoNet is.
limitation is it is one system based, sir. If we go for offline, that
Yeah,
means
you cannot combine your data with other data, so
yes,
there is some limitation, but of course it is one of the promising tool at present for all of us, for the very simple reason that it is freely available for all of us. Okay, so with this we will start with the routine antibiogram, then we will discuss other type of antibiogram. So, routine antibiogram has got three chapters. Chapter number 3, 4, 5. So, first is about data analysis and preparation. Next part is data presentation. Then how to deal with special situations with respect to data analysis and data presentation. So, the first part is about data analysis. Here, these are the points what are discussed under this chapter. We are going to discuss one by one. First is verification of AST data. So verification of AST data means what? Here you have to make sure that only the final verified results are included for analysis. If you have done 2 3 times, like you have tested oxacillin for staph aureus, and you then the result is not satisfactory, so you have tested by 2 3 methods, and finally you have told that it is MRSA by let's say you have done a cefoxitin MIC test, and you have finally you have decided that it is MRSA. So if you done 2 3 times, then only the final verified result needs to be included in the study. There are places where the Vitek will change the result by itself, and such results you have to be very cautious to analyze such results. Any suspicious results available, you have to verify that before you include them into antibiogram. So with this, the next question we will discuss. We have already have done the polling, so I will explain the answer of this. So what happens here? Which of the following Vitek results can be included in antibiogram? Here I'll tell you, as pyogenes penicillin result, if you have a non-susceptible result, then you cannot include into antibiogram. First, you have to re-identify then you have to recheck the AST by a different method, and then if it is still found to be non-susceptible, then you can include in antibiogram. Also you can report to the patient. You can report to the patient as non-susceptible only after re-identification and reconfirmation of AST that it is non-susceptible. As such, you cannot include into the antibiogram. Vancomycin resistance in Staph aureus, it is a highly suspicious result. This also needs to be reconfirm the AST. You have to reconfirm the AST by using a different method. If reconfirmation also shows that it is VRSA, then the current guideline says you have to send to the reference center for VRSA, the ICMR reference center is JIPMA. So you can send to the reference center for reconfirmation that it is VRSA. After this only you have to include into antibiogram. Without that you cannot include into antibiogram. The third is the higher BLI is found to be resistant, the lower one found to be susceptible. Usually it doesn't happen, but once in a while you may get such suspicious result, and you have to understand that beta-lactamase enzyme is not the only mechanism of beta-lactam resistance. There are various other mechanisms like porin mechanism or efflux pump mechanism, etc. Therefore you may get a rare situation where piptas may be resistant and lower beta lactams may be found as susceptible. So the according to antibiogram rule, you may include if you get repeated results. Maybe the first few results of your lab you can retest by a different method, but after you have a standardized protocol, that you may get such results even by repeat test also. There is no need to further repeat for all the future results. So after you standardize by yourself in the lab, subsequently all such results can be directly reported to the patient, as well as you can include into the antibiogram. Okay, so the fourth one is the white tech auto correcting the result. See, E. coli white tech gives a result of I mean the MIC value of E. coli against gentamicin. The white tech MIC value falls in susceptible range. However, the Vitec Advanced Expert System, AES stands for Advanced Expert System of Vitec. It is a software present inside the Vitec machine. Sometimes the software auto correct the report into resistant. It will auto edit the result into a resistant if it doesn't match with the phenotype database available in Vitec. Vitec has got some phenotype database for each organism, and if it doesn't match with the phenotype database, sometimes Vitec will auto correct the result. The guideline says you should ignore such auto correction. You should take the MIC value by its by the raw MIC value you have to take, and you have to interpret by applying CLSI breakpoint. So this is again, you have to ignore the Vitec the auto corrections. Okay, so accordingly, there are four kind of reports, suspicious reports may be possible. One is highly suspicious report. Highly suspicious report, the classical example is BRSA. It should not be analyzed. It should be submitted for to the reference center. Suspicious AST result, here the classical example is all non-susceptible breakpoints. All non-susceptible breakpoint like beta hemolytic streptococcus are tested against penicillin. So non-susceptible breakpoint, again it needs to be reconfirmed, and after reconfirmation you can include for antibiogram. And appears to be suspicious but not, Such examples, the classical example is the meropenem. Looks like a resistance report of meropenem, but the lower antibiotic like piptaz or maybe piptaz or cefepime. So these are the lower beta-lactam. They may appear sensitive. So such kind of cori suspicious, but it is actually not suspicious. The mechanism of resistance may be different other than beta-lactamase enzyme production. You can report as such. And if AES breakpoint mismatch will happen, then you have to reconfirm the report. You should not include the Vitek interpretation. You have to reconfirm by applying the CLSI breakpoint. The second point is facility. Here I will ask you one question. Four antibiograms are produced. Let's say the first antibiogram is produced by Jipmer Hospital for the Jipmer patients, Jipmer clinical department. The second antibiogram is produced by AIMS Delhi. Third antibiogram is produced by PGI Chandigarh. Fourth antibiogram is produced by Lal Path Lab, Delhi. So can you tell me, I mean, among this, which antibiograms is should not be considered? Among these four, which antibiogram should not be considered? Yes, absolutely correct, madam. Lal path lab you should not consider because there is no laboratory specific antibiogram. Antibiogram has to be facility specific or hospital specific. If a standalone lab like Lal path lab is receiving the samples from 4 to 5 facilities, suppose 4 to 5 hospitals, they send the samples to Lal path lab. In such case, the Lal Path lab should produce the facility specific antibiogram rather than the whole laboratory specific antibiogram. So this is the second rule what you need to understand. The third rule is how frequently you have to do analysis. This also Pallav sir has nicely explained. The third rule of analysis is minimum annually you have to perform the analysis for the purpose of empirical decisions. If you want to take empirical decisions, then minimum the annually you have to check the analysis. However, more frequent analysis you can do if you have large number of isolates and facilities are available, then 6 monthly you can do the analysis. Or the second reason is when a new antimicrobial agent is tested, annually you are checking. However, you have introduced a new, so suppose a ceftazidime avibactam you have introduced in the middle in August 2021, you have introduced a ceftazidime avibactam. So if you want to wait for 1 year to complete, then you have to check again in the next August 2021. So in such case, the time period is more. In between every January, your hospital is producing the antibiogram routinely. So for ceftazidime avibactam, the antibiogram can be produced in January more frequently. So because it is a new antimicrobial what has been introduced, therefore more frequently you can. I mean, the at least the first antibiogram can be little recent antibiogram or little frequent antibiogram, because first antibiogram always the clinicians will have more interest to see, because ceftazidime avibactam was never used in your hospital. First time they want to use, so they want to know what is the current antibiotic susceptibility rates. okay, or when other clinical important changes occur, like as I told, as Pallav sir told, you have perceived one outbreak situation, then you will not wait for the next year to next 1 year to get complete. The outbreak data alone you can analyze separately, and you can tell to the clinician that the usual Klebsiella amikacin percentage is usually 22 or 30% is the susceptibility rate, and now we have got a outbreak situation because this particular strain of Klebsiella, the amikacin susceptibility is reduced to 0%. So such kind of analysis can be done, and such kind of outbreak strains you can inform the clinician. Another concept of antibiogram is called as rolling antibiogram. In Jipmer we do something like a rolling antibiogram, where the antibiograms are updated in automatic mode on a either on a monthly basis or on a daily basis. Okay, so two type of rolling antibiogram, that every month the antibiogram are updated, or on a daily basis. The detail of this we will discuss in along with other antibiogram session. Here I am not going to discuss in detail about this. Okay, so in Jipmer, we do a rolling antibiogram where our reporting data gets updated on a daily basis. Like I report today, then after the reporting is over, my data will be automatically updated in the antibiogram. So after that, if I see the result, then the today's antibiogram data will be added to the antibiogram database. So this is called as rolling type of antibiogram. Now the next criteria is isolation selection criteria. Isolation selection criteria, we have discussed that only the clinical isolates to be selected, no surveillance isolate. I repeat, you want to check for MRSA nasal carrier of your all the orthopedic patient you want to check for MRSA nasal caries, so that before the operation, before they go for operation theater, you want to rule out MRSA nasal carrier for orthopedic patient. These data should not be included in antibiogram because it is a surveillance data. Similarly, all the oncology patient, you want to check for the rectal carrier of like for example, you want to check for the rectal carrier of carbapenem resistant enterobacterus, CRE rectal carrier, or maybe VR vancomycin resistant enterococcus rectal carrier you want to check. These kind of data are not included. You are doing a environmental surveillance you are doing, and you have got certain Klebsiella and Acinetobacter from your operation theater samples, then again it is environmental sampling, it is not a clinical isolate, do not include into antibiotic. Okay, now the isolation selection methodology, where the first isolate is been is has to be taken, and the minimum number of isolate has to be 30. So we will have more discussion on these 2 points. First is isolate selection methodology. So first isolate only is the recommended methodology. However, there are other isolate selection methodology also, like for example all isolate also is another method of selection. So the next question is, you have to choose first isolate in all places except one place where all isolate selection methodology has to be taken. So the question here is, which of the following practice is correct regarding isolate selection methodology in the antibiogram? So the first question is, collect and analyze AST result of all isolate. Collect and analyze AST result of only first isolate. Collect uh, the AST result of all isolate. Collect all but analyze only first. Anybody can unmute and tell what is your viewpoint?
So consider only the first isolate.
A is your answer?
C. You collect all, but analyze the first. C is the answer.
Absolutely. So C is the answer. It is not that collect the only the first isolate. The isolate has to be collected for all. Only analysis has to be done for first isolate, because there are some indications where all isolate analysis is required. I will tell you those indications later. There are some situations, there are some indications where you have to test for all isolate. So collect for all isolate, but when you analyze for first isolate. Okay, one more question is there. This question is for date selection. So this question, like you have continuously got E. coli from a patient, 5 E. coli you have got. Out of this, the first 3 E. coli you got in December, and the isolate 4 and 5 you got in January. So here you have how to deal with choosing the first isolate selection technique. Can anybody tell what to do? Unmute and tell. Yes.
For option B, because it is a part of separate.
The option
And
B should be there. Okay.
Ah, option B is wrong. So this is where we do mistake. What we think is
Option
the
A.
time frame is so less that you should not include them. Yeah, because isolate 3 and 4 they have a time frame of just 1 day. Then with 1 day difference, will I include separately? No. So this kind of bias we get usually. But please remember, my dear friends, first isolate selection, it is the date filter which is going to decide, not any other criteria. It is a date filter which is going to decide. You apply the date filter, within the date filter, whichever is the first isolate. That means if you analyze the data, in this example, if you analyze the data for 2020, then your first isolate is this. You analyze the data of 2021, then your first isolate is this. If you want to analyze it, if you want to prepare a 2-year antibiogram, 2-year antibiogram for 2020-21, combinedly want to prepare a 2-year antibiogram. In such case, again, this is going to be your first isolate, one is going to be your first isolate. So it is a date filter. I repeat, it is a date filter which is going to decide, nothing else for the first isolate selection. Okay, so the next slide is about to, I mean, we want to inform you that don't think that first isolate and all isolate are the two selection strategy. There are various other selection strategy also. However, among all this, if they ask which is the most recommended selection strategy, then the answer is first isolate selection strategy. But apart from that, there are other selection strategies also. Selection strategies are classified into isolate based estimate, where all isolates you include. This is called as all isolate selection strategy. Next is patient based estimate, where patient based estimate में you take only one isolate per patient. Patient based estimate, you are going to select only one isolate per patient. That one isolate, either you take the first isolate, which is the most recommended method. Otherwise, there are other methods also, like you take the most susceptible among the isolates, you take the most resistant one among the isolate, or you take a average one among the isolate. So these are the four methods you can take. Only one isolate per patient. So this is called as patient based estimate, where for every patient you are selecting only one isolate. Third is episode based estimate. Episode based estimate, that you consider that 7 days interval you can take as one episode. So within the 7 days interval, you have to consider any isolate, multiple isolate in within the 7 days interval. You take the first isolate of that as the first isolate, and outside the 7 days interval, if you have another isolate, then that you will take as a second isolate. So episode based, so you can you can fix your episode time frame. You can fix the episode as a 7 days episode, or you can also fix as 30 days episode. So within that time frame, the first isolate you will include, and beyond that, you will again select another isolate if it is beyond that time frame. The next is phenotype based estimate, which is based upon the phenotypic differences. Okay, based on the antibiotic susceptibility changes, you have to take the actually the first isolate selection is regardless of antibiotic results, whereas phenotypic based estimate is you are considering the antibiotic results, and based upon that you are selecting various phenotypes per organism of a patient. So you have a question here: which of the following isolate selection methodology will produce the higher sensitivity when used for the same data set?
A.
Higher sensitivity is all isolate or first isolate?
Higher sensitivity first isolate.
Higher sensitivities first isolate. Unlike we think that higher, generally we think that if you take all isolate, then my sensitivity should increase. No, no, my dear friends. Usually, what happens? The first isolate is usually more towards susceptible. The repeated isolates, the resistant trend increases. Therefore, the average of the first isolate is going to be more susceptible than including all isolate. So this is a table. This is a very very interesting table. I hope you all will like it. So this table, I have compared the results of the isolate based criteria means all isolate. Patient based criteria means these are the four patient based criteria where one isolate per patient you have selected, but the data set is same. We have a data set of 5 patient, and for 5 patient, E. coli amikacin of 5 patient, different isolates are there. So the data set is same for all. We will see that by applying different isolation selection criteria, what is the result, what is the sensitivity or result which is going to change. Okay, we'll start. Patient 1, you are following all isolate method. All isolate method, if you are following patient 1, the first patient you have three susceptible results. So three susceptible results you take. A second patient also you have three susceptible result. Third patient you have one. Fourth patient you have one. Fifth patient you have no, that is zero isolates. So the sum of all this is your numerator. The sum of all this is your numerator, that is 8, and the sum of all this is your denominator, which is amounting to 15. So 8 by 15 is 53%. Now you take as most susceptible isolate. So these four categories, you are only taking one isolate per patient. These four category you are taking only one isolate per patient. That one isolate could be most susceptible one, or the first one, or the most resistant one, or the weighted average one. So we'll go one by one. First is most susceptible one. So most susceptible means if you have at least one susceptible isolate in a patient, then you can consider it as S. So patient 1, you have 5 isolate. In that 3 are susceptible. So you can consider this as S because you have at least one susceptible here. Second one also you have one susceptible result available. Third one also you have one susceptible result available. Fourth one also you have one susceptible result available. Fifth one there is no susceptible result. So fifth one is, you consider fifth one is 0. So here The denominator here is here the denominator is 5, because 5 patient, see the patient base estimate, always the denominator is going to be the number of patients. A numerator only will change depending upon your isolate selection criteria. So here a denominator is 5 because you have 5 patients, and numerator is how many are susceptible among the 5. 4 are susceptible, so here the percentage is 80. Next is first isolate selection. First isolate selection, we all know the first result you are going to write. These are the first result of all the patient. So the first result you are going to take. So when you take the first result, again here you have 3 susceptible out of 5, that is 60%. The next one is little tricky, little complicated. You are going to take weighted average. Weighted average means what? Average susceptibility per patient. It is the average susceptibility per patient. Per patient. So patient 1, you have 5 results available. The 5 E. coli amikacin result available for patient 1. Out of that, the susceptible results are only 3. So 3 out of 5 are susceptible for patient 1. So the average is 60%. For patient 2, 3 out of 3 results are susceptible, so the average is 100%. Patient 3, 1 out of 4 is susceptible, so it is 25%. Patient 4, 1 out of 2 is susceptible, so it is 50%. And last patient, there is no result available, so it is 0%. Then you do a average of that, therefore it is called as weighted average. Average of that is A plus B plus C plus D plus E divided by total. So 60 plus 100 plus 25 plus 50 plus 0, that is 235 divided by 5 is going to come 47%. Last is most resistant isolate. Here, if at least one isolate is resistant, then you consider as resistant. Here the rule is at least one. If it is resistant, then you consider this as resistant. That means in the first result you have resistant report, so you take as resistant. Second, there is no resistant report at all, so this you cannot consider. You have to take this as susceptible. Third, you take as resistant because you have resistant report. Fourth, also resistant reports are available. Fifth, also resistant report are available. So here one susceptible out of 5, that is 20%. So these are the various isolate selection criteria. You can see that why I am drawing this, why I am explaining this table to you is the percentage of susceptibility is highest for most sensitive isolate. After that, next highest is if you take first isolate. Then next highest is you take for all isolate, then weighted average, and it is lowest susceptible percentage if you consider most resistant isolate for analysis. So because of all this, they are saying that the first isolate is the best standard among all. Why first isolate is best standard? Why not all isolate? The reason here is, why you want antibiogram? Antibiogram we want for what purpose? Antibiogram we want for empirical therapy purpose. You want to decide which antibiotic you want to give for empirical treatment. So when you are giving empirical treatment, that time whatever sample the patient will be having, that sample will have the first isolate for the patient. Okay, so the patient is admitted with meningitis. You want to start a antibiotic. So that particular time, if the patient is harboring E. coli in CSF, then that E. coli is supposed to be the first isolate of that patient. Subsequently, if the patient has developed sepsis or many other infections, and the subsequent E. coli isolates, even if they are going to become resistant, it is not going to change your empirical decision, because empirical decisions are taken based upon the organism what the patient is harboring at the time of admission. At the time of admission, what organism the patient is harboring, based upon that the empirical decisions are taken. Although the susceptibility of the same organism will change in future, that doesn't influence the empirical treatment test. This is a very simple reason why first isolate selection is the best. Next is
Excuse me,
episode.
sir.
Yes,
So previous slide, please.
yes,
So patient one. So this E. coli amikacin combination we are testing, right? So
yes.
these are the subsequent isolates of the patient one. So these isolates, they belong to same sample or different samples?
Regardless of sample,
Mm.
the isolate selection criteria is regardless of sample.
Okay, okay, thank you.
Clear? Clear? Or any
Yes,
other
yes.
doubt?
No, yeah, clear, sir. And one more, sir. In previous slides, I would like to know about the suspicious antibiotics
Yeah,
in
that
previous.
we will discuss that later, Dr.
Okay,
Sir.
fine. Thank you.
So, episode based estimate again, based upon the date, based upon the date. So you want to apply a 7 days episode criteria. So there are various criteria can be put. You can apply 7 days episode criteria. You can apply 30 days episode criteria. You so based upon whatever episode criteria you apply. If you apply a 7 days episode criteria, then isolate 1 and 2. For example, in this case, isolate 1 and 2 will be considered as one episode. Then isolate number 15 will be considered as another. So 7 days interval mein, whatever isolates are there, among them the first isolate you are taking. Similarly, 30 30, if you go for a 30 days episode interval, then 30 days interval may how many isolates are there per patient, among them the first isolate you take. You can do a different kind of episode based estimate also. Same site, you can apply 30 days interval criteria. If you isolate the organism in a different site, you can apply uh, okay, this is an error here. Same site you can apply 3 month interval criteria. Different site you can apply 30 days interval criteria. That means for a different site, 30 days interval, beyond that you take as new episode. For a same site, longer interval up to 3 month you take as same episode, but beyond 3 month you take as a different episode. So this kind of episode based estimate also you do, but CLSA clearly says that the implication of this is very limited, and first isolate selection criteria is much superior than this, based upon the analysis what they have done. The next is resistant phenotype based selection criteria. A resistant based type, like for example, yeah, you want to check for oxacillin based. So if you want to check for at a single antibiotic example is oxacillin based selection criteria. So you can see here there are three data sets here based upon oxacillin, based upon a single antibiotic data set. There are three data sets available. So among the three data set, you take the first isolate. So you take, for example, this is one data set, this is two data set, this is three data set. So among the first data set, you take the first isolate. Among the second data set, you take again the first isolate. Among the third data set, you take again the first isolate. So in this case, you can take three isolates, because here three different data sets you can make based upon oxacillin susceptibility, and among the three data set you take the first data set of the first isolate of each data set. So this is a example of phenotype based isolation estimation at a single antibiotic. Similarly, the same thing you can extrapolate to multiple antibiotic, where the based upon multiple antibiotic you can take various data set. Again, I am telling you to make you explain how this is calculated, But according to CLSI, the phenotype based data analysis also is inferior to first isolate. The first isolate alone is the best among all. Okay.
Sir,
Yes, Dr. Rosni.
these isolates in the previous slide, these isolates were from the same patient or from different patient?
Same patient. Same patient.
Okay, sir. Thank you, sir.
Patient. If different patient, then there is no need of isolate selection. Okay.
Okay, sir. Thank you, sir.
Okay, then minimum number of isolate to be selected is 30, and the reason Pallav sir has explained wonderfully, so I am not going to repeat the same statement again. 30 is the minimum number of isolate to be examined. Okay, minimum number should be 30. Next is antimicrobial agent selection criteria. You have a we have discussed isolation or selection criteria. Now we'll discuss antibiotic agent selection criteria. So you have MCQ here. So can you answer this? I mean, you have already answered. No, no. This is a new question. So can you on the poll, please? Neeraj, can you on the poll, please?
Yes, sir.
Yeah.
I'm launching poll 5.
How many questions are there?
4 questions in this poll. 2 minutes timing for polling.
4 questions.
4 questions. Time start now. Fifty seconds left.
Sir, you are on mute.
Okay, okay.
Sir, you are on.
Yeah, sorry. So the first question is about selective testing. Selective reporting is different. Selective.
Time's up. Polling is closed now. I'm sharing the results.
Yeah, you can share the result. The first question is about selective testing. Selective reporting is different than selective testing. Selective reporting is you test for all, report selectively. Selective testing is you test selectively. So all these are example of selective testing, and remember that if antibiotics are tested selectively, then they should be excluded from analysis of antibiogram. Okay, you include only routine antimicrobial agent tested, exclude the selectively tested antibiotics. All these are examples of selectively tested antibiotic. You are testing only on ICU patients, only on OPD isolate, only on extra payment. Some isolates are tested only on MDR isolate. Some antibiotics are tested only on XDR isolates. All this exclude from analysis. So therefore, the golden rule what Pallav sir has already informed us is lab should include all antibiotic for testing. Even yesterday also I have told us same thing in the session. We should include all antibiotic of testing. Only reporting should be done selectively. So why reporting is done selectively?
So I
Anybody?
have a question. So if we're giving antibiogram, for example, for an ICU, cannot we include the antibiotic we are testing for ICU only in that if we are giving area wise?
Yeah,
Or
agreed, Dr. Abirujan. That case, it is possible. The selective tested antibiotic can be used.
if we
Excellent point.
yes sir, if
Can
we're giving for that area only.
I mean, Dr. Abidu, you have told a very, very important point which I missed. I should be thankful to you. So,
Yes, sir.
a selectively tested antibiotic can be included for antibiogram for analysis of that particular category. For example, if you want to if you want to analyze the ICU patients only, then you can include these results for ICU patient analysis also. So excellent way of understanding the concept. So now why we do antibiotic suppression? Why we suppress antibiotic? The suppress antibiotic we do for various reasons. We suppress antibiotic for the sake of selective reporting. We suppress the antibiotic for sake of cascade reporting. Such cascade reporting means broad spectrum antibiotics are suppressed if narrow spectrum antibiotics are susceptible. This is called as cascade reporting. Narrow spectrum antibiotic, if they are susceptible, then you suppress the result of broad spectrum antibiotic. Then we also select the suppress the antibiotic because of product limitation in Vitek. Vitek, for example, Acinetobacter amikacin result will never come in Vitek because the Vitek deliberately has suppressed the result. Though the panel is having the antibiotic, Vitek doesn't give Acinetobacter amikacin result because of product limitation. They have a limitation. They have not got certain approvals. That is why they are not releasing the result. However, you can uncheck that. However, you can unselect that and you can make this result available for analysis. For the patient result sake, you can suppress, but for antibiogram analysis, you have to include the product limitations also. So all these three, whether it is selectively reported, or it is cascade reported, or it is or you have suppressed the antibiotic because of product limitation. For all these three reasons are together called as antibiotic suppression. M39 has clearly given antibiotic suppression means the three categories of antibiotic suppression, and all these three you have to release. I repeat, you have to release the report for patient. Uh, Patient I mean, yeah, for the antibiogram sake, mostly you have to release the report. There are two more reasons why we suppress the antibiotic: if intrinsically resistant or if breakpoints are not available. In these examples, intrinsically resistant or breakpoints are not available, but you have tested because Vitek is having that antibiotic, because Vitek is having because Vitek is having minocycline in 281 panel. Therefore, it is tested even for Pseudomonas aeruginosa. In spite of knowing that Pseudomonas aeruginosa is intrinsically resistant to minocycline. In such case, my dear friends, please remember, Vitek may wrongly show the result also. Vitek may wrongly show the result as resistant. Mostly it will show the result as resistant. Sometimes it may be pseudo susceptibility also, it may show the result. In such case, please do not include for patient report as well as for antibiogram. Both for patient report as well as antibiogram, do not report if it is intrinsically resistant. Breakpoint not available, again you should not include. So the next few slides are on that actually. All of the following antibiotics can be included for routine antibiogram, except here the answer is first and second generation cephalosporin for aminoglycoside. This is an example of selective reporting. You have not reported first second generation cephalosporin for aminoglycoside for salmonella because it is clinically ineffective. Because it is clinically ineffective, you have not reported. So this is an example where you should not include for antibiogram because it is clinically ineffective. The next is sample specific suppression. Again, they have clearly told that for sample specific suppression, only nitrofurantoin, norfloxacin, nalidic acid, these are the three urine antibiotic which should be reported only for urine, and it should not be included in antibiogram also. The other examples in the list are sample specific suppression for patient report. For patient report, you have to suppress these antibiotics. However, you can include them for antibiogram. So the next slide, I have the detailed explanation of this. I can show you. One more.
Sir, one doubt, sir. Sir,
Uh,
daptomycin in respiratory,
you,
usually patient reports we don't give, no, sir.
you please ask the doubt after my
Yeah, sure, sir.
my discussion is over on this particular point. Okay.
Okay, sir. Sure.
Which of the following antibiotic can be included for routine antibiogram? The next question here. Here, please remember that amikacin result for acinetobacter tested, you have to include for antibiogram. It is usually a product limitation. I have already told you it is usually a product limitation. But you have to include for antibiogram. You have to make the result available for antibiogram because it is a Vitek product limitation. Similarly, carbapenem results are suppressed from patient report when first and second line agents are found susceptible. This is a classical example of antibiotic cascade reporting. This is a classical example of cascade reporting. Again, you have to include for antibiotic. The next option is minocycline pseudomonas. I told you it is intrinsically resistant, therefore exclude. Ciprofloxacin stenotrophomonas. Here no breakpoint available, therefore exclude from antibiotic. So the next slide, I will go a little fast because everything we have already discussed. It is the summary slide. So I told you that antibiotic suppression is of three classes. Antibiotic suppression is of three classes. First is selective reporting. Second is cascade reporting. Third is product limitation of automated system. So what is the various type of selective reporting? The various type of selective reporting can be classified on the factors. The first factor is organism identification. So clinically inefficacy is the criteria. The example is salmonella. You are suppressing the report of first, second generation cephalosporin and aminoglycoside. This is not intrinsically resistant. It is clinically ineffective. So you have to suppress from patient report as well as from antibiotic. However, clinically not reported. Here the example is in salmonella, the piptas, meropenem, imipenem, magnex, all these reports are available in Vitek, but I do not report to the patient because of simple antibiotic like ceftriaxone, which has been the drug of choice for salmonella for ages, is found to be always 100% susceptible. Therefore, my lab do not report these antibiotics to the patient. So yes, this can be suppressed from the reporting, but this need to be included for antibiogram for for your for your laboratory purpose. However, when you display the antibiotic result to the clinician, that time you can suppress these results because this is usually not required for the clinicians. For requiring purpose for the clinicians, you can suppress. You need not display the antibiogram report of this to the clinicians. However, you have to include for antibiogram because it is required for your national database. Therefore, you have to include for your antibiogram. Next is mechanism of resistance. Like ESBL screen is positive by Bitech. In such case, whether your lab is going to suppress all third generation cephalosporin, answer is no. Yesterday we have already discussed. You have to report as such. Even for patient reporting purpose, also you should not do selective reporting. You should report as such, and you should include the respective report into the antibiogram. Next is based upon various body side. Based upon various body side suppression, then you know that there are certain antibiotics which are suppressed for certain specific body side. All these are suppressed from the patient clinical report because they do not work on the respective body side. However, for antibiogram purpose, what is required is you should not include for antibiogram only for nitrofurantoin, norflox, and nalidixic for non-urine specimen because of the simple reason that these three antibiotics are not given at all for other indications. They are only urine active antibiotic. But daptomycin respiratory specimen it is not given, but daptomycin is given for other indications. Therefore, same for chloramphenicol, macrolide, and clindamycin. Though they are not given for urine isolates, but they are given for the same isolate. Like the same patient is having E. coli in urine and E. coli in any other site, for example, blood. Then in such case, you may consider using antibiotics. So please remember that they should be included for antibiogram entry purpose. Now I will tell you one situation. You include except nitrofurantoin and norflux, rest all you include for antibiogram data analysis. However, you want to produce a respiratory antibiogram, you want to produce a respiratory antibiogram, then this particular information you have to hide from analysis. But you want to produce a all sample antibiogram, in such case you have to include these data for analysis. Even the respiratory or daptomycin is restricted, but include for all sample analysis. So this is what I wanted to explain you, that body site specific restrictions are important for patient reporting but not for antibiogram purpose. Clinical setting, IV drugs are suppressed for OPD patient. Yes, you can suppress, but you include for antibiograms purpose. Ciprofloxacin, tetracycline, etc. are suppressed for children. You can suppress, but you should include for antibiogram. Aminoglycoside, renally unsafe antibiotics. The renally the renally unsafe antibiotics can be suppressed if the creatinine is high. The patient with increased creatinine, you can suppress this antibiotic but include for antibiogram. And already we have discussed any suspicious result, unless otherwise it is not enlisted in that list what I have shown you earlier. Like for example, amikacin resistant genta susceptible, or piptase resistant carbapinam susceptible. All these are possible because of different resistant mechanisms. For patient reporting, it is your choice. It is absolutely your choice, but for antibiogram purpose, you need to include. Next, so all these are example of selective reporting. Next is cascade reporting. Cascade reporting, I told you that the broad spectrum antimicrobials are suppressed if narrow spectrum and cheaper agents are susceptible. The classical example is vancomycin is suppressed for MSSA. Carbapenems are suppressed when first and second line agents are found to be susceptible. All these are the examples you very can suppress from the patient report, but you include for antibiogram purpose. Product limitation also we have discussed. All these are the drug bug combinations which Vitek does not produce the result because they have not obtained the enough FDA clearance. You can suppress for patient reporting, it is your choice, but take the breakpoints and analyze by CLSI. I mean, take the MIC value from the breakpoint. Vitek only will suppress the result, but Vitek my MIC values will be available. So take the MIC values and report to the patient. So I mean, sorry, take the MIC values and interpret based upon the CLSA breakpoint and include them for antibiogram. Patient reporting, again, it is optional. Usually it is suppressed. It is your choice to decide, but antibiogram purpose definitely you have to include. However, intrinsic, resistant, or breakpoint not available, all need to be excluded from antibiogram also. Okay, so this is what. So now you can ask that why we have to check only if it is intrinsically resistant, because ideally should not be tested only, but we are forcefully testing this antibiotic for some reason. Because one reason is identification may not be available at the time of putting of AST or antibiotic, because it is by default included in the Vitek panel, therefore may be testing, but you should exclude them from analysis as well as from the patient reporting. So this is all about various type of antibiotic suppression. I hope you have understood. uh, Next we will discuss about surrogate agent. Surrogate agent, whether to include, how to include. As the Pallav sir has already told, surrogate agent, you have to test only but report the reported antibiotic. For example, cefoxitin and oxacillin. Cefoxitin is a surrogate marker for oxacillin. So testing purpose you use cefoxitin. The laboratory information purpose, you can, that data generated from testing of surrogate agent may be storing into the laboratory data should be on cefoxitin. But when antibiogram is generated, it should show oxacillin susceptibility rate, not cefoxitin susceptibility rate. So antibiogram generation purpose, the reported antibiotic is included. However, for the surrogate marker can be included for the storing purpose. Okay. Next is denominator and numerator data. Can you on the poll? Can you on the poll, please? Neeraj, can you on the poll?
Yes, sir.
Yeah, please respond now when I am telling. You're taking so much time to respond.
Poll
Please.
number 6 launched. We have 3 questions in poll 6. 1.5 minutes for polling. Starts now.
Okay. In this time, if somebody has some doubt, can ask, because somebody was asking me question. I told you to ask a little later. If your doubt is clarified, then it is fine. If you still have doubt, you can ask me. Ducto respiratory, you were asking. I have explained already. I hope your doubt is clarified.
Yes, sir. Clarified, sir.
Thank you.
Sir, selective and cascade reporting are same.
I have explained, no, they are different. I have given you a detailed example what comes under selective and what comes under cascade. Actually, some books write that cascade is a type of selective reporting.
Yeah, yeah.
You can,
Dr. Apurva,
yes,
I
yes.
just want to ask one question. If I receive two samples, that is one pus sample and one respiratory sample, and I got same organism in both the samples on the same day. So which sample I should, which isolate I should include in pus or in respiratory sample?
A sample collection will decide. Sample
So
collection,
which,
sample collection cannot happen. Two sample collection cannot happen at the same time, right? It has to be,
okay,
it has to be one after the
I
other.
have to, I have to confirm from there.
Yeah, you have to confirm on that. See,
Okay, thanks.
these are very very intricacy in a day to day practice. The date of sample request generated is usually taken. You
Thank you so much.
the in the LIS we generate the request, right? So in LIS when we generate the request, so whichever request was generated first by the clinician, that usually taken as the first isolate. But actually speaking, the sample collection time should be the determining factor for first isolate selection. That is the best
Okay,
determining factor.
So
thank
can
you
I
so
share
much.
the result?
Yeah. You are free to share the result. So the denominated data is all. Remember that all isolates should be included for the denominated data. Whereas numerated data, the next question, numerated data, you include the susceptible data, and SDD and iCaret data should also be displayed separately if available. Numerator data, you display the susceptible data, and SDD data, if it is available, you can also display separately. So the explanation I will tell you in the subsequent slide. So performing calculation, this is what is going to discuss. So the SDD and iCaret result, how to display, I will be telling you in the subsequent slide. Performing calculation, so this is what we have discussed. Next is selected organism specific additional analysis. So these are the three organisms for which additional analysis is required. So we have one question for you here. So please answer this. Can you on poll 6.3? Oh, 6.3 is already over, right? So here the answer is, please remember that all isolates should be, all isolators should be interpreted twice using meningitis and non-meningitis breakpoint, and then should be displayed separately into the antibiogram. So for pneumococcus, the guideline is clear that if you get a isolate from meningitis isolate, then the meningitis breakpoint you apply and you report to the patient, and you report to the patient. For another patient, for patient B, the first one is patient A, for example. For another patient, you get a sputum isolate. Use sputum isolate of pneumococcus, you apply non-meningitis breakpoint, and whatever is the result, you report to the patient. However, for antibiogram purpose, the meningitis isolate, that is the first isolate. For antibiogram purpose, the patient A isolate and patient B isolate. Both the isolate you interpret separately by using non-meningitis and meningitis breakpoint. You have to interpret twice. You have to interpret twice by applying both the breakpoint. Then you have to combine and display the data separately, how it is been displayed by CLSI. So you, if suppose if you have received 110 isolates, 110 isolates, few, maybe suppose 40 isolates are from meningitis, 70 isolates are from non-meningitis. However, meningitis, non-meningitis, when you are displaying, you are not displaying as 40 and 70. No, it is wrong. All the 110 isolate you have to interpret by meningitis and non-meningitis separately. Other places the results will remain the same. Only for the penicillin the result will vary, because for penicillin only you have meningitis and non-meningitis breakpoint separately. Also for ceftriaxone and cefotaxime, these three you have separate breakpoints. So in these three places you will have individual meningitis and non-meningitis results. Similarly, next is for staphylococcus, how you will analyze. For staphylococcus, all staph aureus, then MRSA and MSSA. All three should be displayed separately. So it is not that only staph aureus. No, it is MRSA and MSSA. MSSA antibiogram also should be displayed separately. I want to ask one question here. Can you explain in this data set, if you have 449 MRSA and 904 MSSA, then why all isolate number is showing more than 904? Anybody, any of you can unmute and answer? Anybody can unmute and answer? Why here total isolate is showing more?
Sir, they can be Borsa.
Isolate
So
can be
it
either
is less.
or MSSA. It cannot be both, right? So
So
how?
it is less.
Huh?
So it is less.
Sorry, it is.
Total number. It
Yeah.
is less.
Sorry, it is
1353
less.
actually.
It is error here. It is less. Correct. It is less. So my question is, why MRSA plus MSSA isolate number is coming as less than all isolate?
It's
So,
more only.
huh?
More. 904 plus 449 is 1353.
Correct. More. Sorry, I got confused by 9449 plus 904 is what? 1353.
1353.
Yeah. So correct. What I have written is correct. Why 1353 is a greater than the actual number? The reason here is, if anybody is explaining, is telling fine. Otherwise, I will explain. The reason here is.
First isolate only.
Pardon? Yes, you're right, madam. Please tell me.
Included the first isolate only for making the antibiogram.
Yeah, so here what we are doing is, the total data set is your 13. The total data set is 1317. Here, how many patients are there? How many patients are there? If they will ask, answer is 1317 patients are there. In 1317 patients, if you then you apply the first isolate filter. Here the first isolate filter is applied on the three data sets separately. Okay, all staph aureus data set, MRSA data set, MSSA data set, all three data sets are first created. Then you apply the first isolate filter, and therefore the data has become different, because in this particular example there are 36 patients who are harboring both MRSA and MSSA isolates. There may be subsequent isolates became MRSA. So therefore those patients, when you include in all isolates, suppose I'll give you one example. One patient is there, he has got three isolate. Suppose the first isolate is MSSA. I mean, the first isolate is oxacillin sensitive. The second isolate is sensitive. The third isolate is resistant. So this patient, in the all staph aureus data set, you will consider this patient as sensitive. Oxacillin you will consider as sensitive. However, if you create the MRSA data set, if you want to create the MRSA data set, then this patient ka first MRSA isolate is going to be the third isolate, and you will include this into the MRSA data set. This patient also you will include into the MSSA data set, because the first isolate is going to be MSSA. So I repeat here, this particular patient ka data will be included in all staff or his data set, will be included in MSSA dataset, also will be included in MRSA dataset. Because the subsequent isolate, the third isolate, which is resistant to oxacillin, this will become the first MRSA isolate of the patient. So that is why in this example, there are 36 patients who are harboring both MRSA and MSSA isolates, and therefore that got added up, and that is why the total number is going is becoming more than the number of patients. So little complicated analysis. I hope you have understood. If not, you can discuss with me later. Next is antibiogram for enterococcus. Enterococcus also they have told that faecium and fecalis need to be analyzed separately because their antibiograms are totally different. So fecalis and faecium, faecium is supposed to be more resistant. Therefore, fecalis and faecium need to be analyzed separately. So this finished the first part of the presentation. Have I finished my 1 hour time slot? What time we started?
Yes, sir, we are running late.
Okay, so no problem. So we will continue because this routine antibiogram is going to be the base behind the antibiogram sessions. So the next part of the routine antibiogram is data presentation. The third part is special situation. So data presentation, so these are the data to be collected. So data presentation, before that you should know what are the data need to be collected. Pallav sir has already told you have to collect. You have, see, for routine antibiogram you need not collect all the data. For routine antibiogram, only the antibiotic data is enough. Only the only the demographic detail and antibiotic data is enough. However, for stratified, for enhanced antibiogram, you need to collect other informations like what is the sample type, what is the facility, or what is the admission date, what is the specialty. All these are required for for enhanced or stratified antibiogram. Routine antibiogram, of course, minimum informations are required. So these are the informations what are required can be classified as demographic detail, and the stratified informations for the enhanced antibiogram, and the third is for AST report. Here you have to write down the AST data, that is MIC value and interpretation. Here I want to tell that do not collect only the interpretation. Interpretation, if you collect not any other thing, then if the breakpoint will change later, then you cannot reinterpret. So always collect the MIC value also along with interpretation. Always collect either the MIC value or the zone diameters along with interpretation, because that is what is going to make the difference. If the breakpoint will change later, then you can reinterpret.
Excuse me,
Okay.
please, Dr. Apurba.
Yes.
So if the breakpoint changes in the subsequent CLSI,
Breakpoint we are going to discuss in my subsequent slides, ma'am. So you please wait for that particular slide. After that, you ask your doubt.
yes, yes. Thank you very much.
Okay, so the presentation is also important because it is the presentation which makes the difference. It is not the content. Of course, content also will make the difference, but the presentation will make the content more appealing. So the how you want to present your antibiogram data to the clinicians: x-axis antimicrobial reagent, y-axis organism name, and you to display the percentage of sensitivity for each organism agent in the respective box. So this is how CLSI draft document has given. This is how the antibiogram needs to be produced. X-axis the antibiotics, y-axis the organisms, and here the susceptibility percentage. Do not include I and R results. only the susceptibility percentage need to be included. However, you have to give certain symbols and certain abbreviations also to inform additional informations. So these are the various abbreviations which are required. I will explain you about these abbreviations in my subsequent slide, in my next slide. So these are the various abbreviations you may have to apply in your antibiogram table. So next, yeah, so you can see that this is a standard routine antibiogram. So as I told you, the antibiotics are there in the x-axis. In the x-axis, this x-axis antibiotics can be presented in two ways. How I have presented here is, I have presented as first line, second line, and restricted antibiotic. Because this is how my clinicians want to see the result. You can also present this in a alphabetical order. All antibiotic you can present in alphabetical order. This is the second presentation. Third presentation is, you can present the antibiotics in by their chemical class, like aminoglycoside, quinolones. Like that also you can present by their chemical class. So these are the three way you can present by the spectrum of activity into first line, second line, and restricted, or by the chemical class, or by alphabetical. All three are acceptable. It depends upon what is the purpose of your antibiogram. If your purpose of your antibiogram is to supplement empirical therapy decision of the clinician, then it is better to have the spectrum of antibiotic based display. Then there are various abbreviations. I have told you, you can apply various abbreviations. For example, intrinsic resistant, you can, wherever intrinsic resistant you can display, wherever no breakpoint available you display, wherever clinically ineffective your salmonella aminoglycoside and salmonella, the aminoglycoside is clinically ineffective. So clinically ineffective you can display. Wherever you have not reported, I told you that in salmonella there are many antibiotics we are not reporting because it is not required, because ceftriaxone the sensitivity is 100% or 99%. Therefore there are many antibiotics I don't report. So not reported antibiotics you can write as NR. So these are the various abbreviations which need to be added to your antibiogram report. And susceptibility inferred, SP is susceptibility inferred. For example, the ceftriaxone susceptibility can be extracted for cefotaxime for Enterobacteriaceae family. So for Enterobacteriaceae family, so not for Acinetobacter. Acinetobacter is wrong here, but for Enterobacteriaceae family, the E. coli Klebsiella, for example, the ceftriaxone can be extrapolated for a cefotaxime. So if you're testing for ceftriaxone, then your antibiogram data can have SP for cefotaxime. SP means susceptibility inferred. Okay, so these are the various things. And uh, uh, and of course, if your analysis for particular organism is for extended period, so this particular antibiogram you can see here, it is for 2020. It is a 1 year antibiogram. However, salmonella I have prepared for 2 year antibiogram because my number of isolates are less. Therefore, I have prepared salmonella for a 2 year antibiogram. In such case, the abbreviation should mention that salmonella, the date of 2019 and 2020 data are included. Okay, so this is how you are going to present. Okay, and next is color coding. So, sorry. Next is color coding. So color coding means you can see this is a basic level of antibiogram what we have discussed. The same antibiogram you can color code also. For example, you can give a green color for more than 80% sensitive antibiotic. Yellow color you can give for 60 to 80% antibiotic. What happened? Yellow color you can give for 60 to 80% antibiotic. Red color you can give for I don't know what any problem. Okay, so this is the color coding what I have done here. So I have color coded. I have done the color coding of all more than 80% antibiotic as green color, and 60 to 80% antibiotics susceptibility as yellow color, and red is less than 60%. The meaning of this is the green color antibiotics are excellent for empirical therapy. The yellow color antibiotics are can be given for empirical therapy, but it is doubtful. I mean, it can be tried if green color antibiotics are not available, whereas red color antibiotic, the susceptibility is less than 60%. Therefore, it should be prevented from empirical antibiotic therapy. So this kind, so clinician will be more interested to see such report because it is more clear to them to choose which antibiotic. Okay, so after the antibiotics is prepared, please remember you have to validate the antibiogram report. You have to make sure that the inclusion criteria, exclusion criteria, everything, the isolate selection criteria, antibiotic inclusion criteria, all these are properly done or not, or whether the stratification filters are properly applied or not, whether the abbreviations and comments have come appropriately or not. All these you have to validate the calculations. The calculations need to be validated, and you have to give a final check to the antibiogram data, whether any flags are there, very any highly suspicious results or suspicious results. All these are verified properly or not, whether the QCs are going on properly or not. All these you have to verify properly. Then only you should generate the report to the clinicians. Okay. So the next is the cultural practices and temporal outbreaks. This is, can you on the poll, please?
So I had a doubt. Can I
Yes,
ask?
yes, Sagar.
So
On
in
the
the
poll,
table,
please.
so in the table, you have included cholesterol also, but you said only the susceptible organisms have to be included. And as per CLSI, cholesterol is either intermediate or resistant.
So colistin may be considered as one exception because colistin intermediate meaning of that is you can give to the patient if other antibiotics are tested resistant. The intermediate colistin report how you have to take is you should not give otherwise because it is intermediate. But if it is all other antibiotics tested are resistant, then you can give colistin for that particular objective, for that particular purpose. You may include because it will be useful for the clinician.
Okay. Thank you, sir.
Why you're not owning the poll? uh, I am going to skip because I don't have time. I cannot wait for you to on the poll. So I am going to the next slide. So cultural practices. Cultural practices, they say that the cultural practice will influence antibiogram. Can you tell me among these five choices, which cultural practice will not influence antibiogram? Which cultural practice is risky? Because I have discussed earlier selectively testing. This particular slide tells about selectively sending culture, sending culture practice. So if a lab if a lab obtain culture only for selective patients, then again this is not suitable for antibiogram. then it is not suitable for antibiogram. So please remember, you have to influence the clinician to send culture. That is the first step towards antibiogram preparation. Okay, so you have to convince the clinician to send culture. Otherwise, the value of antibiogram is of no use. The next question is about temporal outbreak. Okay, I'm skipping the question to save time also. So if an outbreak is going on, whether you can include the isolate data or you should not include the isolate data. I'll tell you one example. Citrobacter fruendi in a hospital A, all of a sudden you have got 40 isolate in 2021. The earlier 2022 result says that you have uh, you have got less number of isolates, but okay, in Cytobacter fruendi in hospital A, altogether you have got 40 isolate in 2021. Out of the 40 isolate, the routine non-break isolate are 30, where 29 are susceptible to meropenem. The June outbreak isolate are 10, and all those outbreak isolates are resistant to meropenem. In such case, if you exclude the outbreak data, if outbreak data is excluded, then what will happen is 29 are susceptible and the total isolate will become 30 because you have excluded the outbreak data. So the susceptibility rate is 96%. If you include the outbreak data, then the denominator will become 40. The susceptibility is again the same because in the outbreak data nothing is susceptible, and it is going to become less, 70 to 5%. So now you tell me whether you will include the data or you will exclude the data. The answer to this question is based upon the objective what you have. If your objective is to decide on empirical therapy decision. Please remember, antibiogram ka main objective is to guide empirical therapy decisions for the initial infection. If your objective is this, to guide empirical therapy for the initial infection, then you can exclude the outbreak data, because outbreak data is not going to influence on empirical therapy. Because on a long term, the antibiogram data is going to be based on, the empirical decision is going to be based on the initial infection. It is not related to any outbreak information. However, if your objective is why you want to compare the 2020 data with 2021 data, if you want to compare with the previous year data, if you want to compare between the community, in this year, in this 2021, I want to compare the data between hospital A and hospital B. If these are the objective, then you have to include the outbreak data. So the rule here is include the data. The antibiogram entry purpose, you include the data. Then when you generate the report of antibiogram, whether you include for analysis or not, that can be kept as optional. Okay, now there are special situations where you have to check the thing. So the first question here is SDD and intermediate SDD and I category, SDD and I caret category, this to include or not. Answer is yes, because SDD is susceptible in increased dose, and I caret, yesterday we have discussed, it is susceptible in increased dose for urine specimen. Therefore, these data are actually susceptible data. There are various way of presentation. Either you present them as S percentage and S plus SDD percentage. both together you can display separately. This is or you can display as a footnote. So how you are going to display is different, but you include the data. This is a table where the S plus SDD they have displayed together. So they have clubbed the data and they have displayed together. Okay, so next is cefazolin. I told you that the cefazolin has a systemic and a urine breakpoint separately. Therefore, you should display separately both the breakpoint data of cefazolin. Okay, okay. Now the next question. I want you to answer this because this is a very tricky question. Okay, don't no need to on the poll. Any of you can just read it and answer which is not acceptable method to manage small number isolate. Which is not acceptable method to manage small number isolate.
So data up to genus level can be combined.
You don't think it is acceptable? Like you don't have a Citrobacter fruendi 30 isolate.
Can I start the polling?
No, don't start the polling. We will skip the polling.
Okay.
Can you Citrobacter fruendi? You don't have 30 isolate, so you want to combine to genus level all.
F answer, sir.
Yes.
Answer F.
Yes, analyze on all isolates data instead of first isolate.
Madhuri, you're Dr. Madhuri?
Yes, sir. Yes, sir. Dr. Apurba Sastry.
I am so happy that you have answered this.
Analyze.
Yeah.
I am so glad that you have answered this. Analyze all isolate data instead of first isolate is wrong. Is totally wrong. Please do not do that. Rest all are acceptable method. Even if you can present as a footnote and write that it is calculated from fewer than standard recommended method, this is also is acceptable, but do not analyze on all isolate data. Okay, so this is explanation for this we have already discussed. Then the next is change of breakpoint. So somebody was asking about breakpoint change. So again, the rule here is if breakpoint changes during analysis period, then you have to reinterpret with the new breakpoint for the whole period. If the breakpoint is changed in April, so you want to analyze the whole year, then even the January to March data also you have to uh, interpret by the new breakpoint. Okay, so if the breakpoint is changed in April, so that means Jan to March you have used old breakpoint. April onwards you have used new breakpoint to report to the patient. But when you are analyzing for the whole year data, 2021 antibiogram when you produce, the rule says that you have to reinterpret for the whole year. The whole 2021 year you have to reinterpret with the new breakpoint. However, if the breakpoint changes between the analysis period, then whether to interpret with the new or old breakpoint is purely dependent upon your aim of your research question. I would like to thankful to Dr. Janet here, because this is what we could not understand in CLSI chapter 5. We could not understand the wordings given in CLSI. So we have contacted Dr. Janet from US. She's a member of CLSI, and she has given us this table. So this table is not available in CLSI book, but she has explained us the reasons, and we have prepared a table out of this. I will explain you it. If the breakpoint changes between analysis period, then it depends upon the aim of your research question will decide whether you will use new breakpoint or old breakpoint. If you want to examine the changes in the susceptibility of year to year changes of your susceptibility, if you want to examine the change in the susceptibility, the susceptible trend you want to analyze, then you have to use new breakpoint for the whole period. Okay, I just take a 5-second break. So if you want to change, if you want to determine the susceptibility trend, you want to determine the susceptibility trend, then you have to analyze with the new breakpoint for the whole analysis period. However, if you want to check that the isolates are susceptible or not at the time of breakpoint, then you have to use the respective breakpoint. Okay, so these are the rules. I have some examples which will give you more clarity on this. Okay, so don't, I mean, there is no need of pause, just try to answer this. Yes, yes. Don't, no need to raise hand, you answer.
It's B. B.
B.
B.
It's B.
A.
Sir, it's B because the breakpoints have now been edited. So we do the
It
whole.
will be A.
What is the objective? The objective is you want to see the sensitivity of ciprofloxacin in 2018. So somebody wants to know the ciprofloxacin susceptibility in 2018. The old breakpoint only you have to use to analyze. The next question is the same question, but you want to see the susceptibility of 2019. Here, what you have to do?
Now we use the newer.
Yeah. So do not do this. Many will be thinking to do B. No, don't do B. You use the new breakpoint for 2019. Okay. The next question is, then the next question is, you want to see the susceptibility trend of ciprofloxacin from 18 to 21. The susceptibility trend you want to see.
B. B.
B.
Yeah, if you want to see the trend, then the rule is for trend analysis, you have to use new breakpoint. Excellent. I'm so happy that you guys are understanding so clearly, because to understand the breakpoint change, me, Ketan and Dipasri would have spent at least 5-6 hours to break our head. It was so complex for us to make us understand. So this is how you have to do. So it all depends upon the objective of your study. So the based on the study objective, it will decide which breakpoint to use. So this completes the session here. I have taken maybe half an hour more or something like that. I have a deep apology to the organizers for this. Now we will move on to the enhanced antibiogram, and Dr. Dipashri, are you ready?
Yes, sir. Yeah.
You are going to present. I will close it, or you will present from here.
No, sir. I'll share my screen, sir.